Good morning and welcome to the Sanibel Symposium. My name is Carla Mall and I will be your moderator this morning for our breakfast session. This session is sponsored by Hemosonics. Our speaker today is Dr. Melissa Berger, who is an assistant professor and an anesthesiologist at the University of Florida. Dr. Berger will present Making Viscoelastic Testing Work, a scene from the OR and real-world data review. Dr. Berger?
Thank you. All right, all my perfusionists in the house, let's get this breakfast started. So we are going to be talking today about transfusion and what a difficult task it can be in the operating room. Cardiac surgery is one of the biggest users of blood products. We use an incredible amount of blood products. And despite the fact that you have all these guidelines telling you to use viscoelastic testing, probably about 20-30% of cardiac surgery centers actually use viscoelastic testing of any variety. Raise your hands if you use any type of viscoelastic testing, whether that be a Quantra, Rotem, thromboelastography. So as you see in the room, not that many people using it in their centers. Despite what guidelines say, our feeling is the reason that some of this may be difficult to implement is because the time it takes to get the blood sent from the OR to the lab, and then the lab actually has to put it on the machine, and the machine has to run, and most of these devices take between at least 30 minutes upwards of an hour and a half before you get a result. And then the result has to get reported back to anesthesia and perfusion to actually make a decision to do something. And in that time frame, you've had all sorts of evolving coagulopathy. You may have given blood products, who knows what. And so as you see, the majority of cardiac surgery centers don't use viscoelastic testing. And no real guidelines exist as far as if you do have a certain number on your Rotem or your TEG, what should you give in response to that number? So we're going to take you into a little scene from the operating room. We have surgeon Tim Skinner, we have our perfusionist, Asser Girgis, and myself, the anesthesiologist. And so kind of giving blood, you see, becomes a bit of a guessing game, and we'll show you how that goes down in the operating room.
Okay, can we start rewarming?
Thank God. Rewarming, thank God. Okay.
Wow, it's been a really long case.
Yeah, it has been.
This patient's going to be on bypass forever. My goodness. All right, I'm pretty sure he's going to be pretty coagulopathic. Come on, Gon. You know what? Do you mind if we send out some labs? A CBC, platelets, fibrinogen. Odds are that this patient is probably going to be Uzi, and we honestly just need to kind of get ahead of the game. The blood takes forever.
That's a great idea. I'll just go ahead and get some blood out, send it off to the lab, and maybe by the time we come off bypass, our stuff will be back.
So why don't we just order some blood drugs? By the time the blood bank gets it prepared and sent over, we can use what we want, send the rest back.
Okay, I'll just order a couple of everything, and we'll have it on hand to give when
Sounds
we need
great.
it. 2 hours later. All right, protamine's in.
Man, this guy's really oozy. Can you give him something to correct for the bleeding?
Yeah, I'm working on it, okay?
Can you work a little faster, please?
Yeah, we're trying to get this done, okay? Let me see if our stuff is back from the lab yet. It's been probably over an hour at this point. Hello? Yeah, hey, is this the central lab? Yeah, so I was just wondering if my results are back yet. They're still running. Oh, man. Okay, fine.
Hey, what are y'all doing over there? Can you help us with this bleeding?
I mean, I don't really know what to give. It's kind of going by clinical judgment here. I don't know.
Maybe we need some fibrinogen. Come on, guys, look at this chest. It definitely looks like he's got a deficiency, maybe a platelet deficiency, don't you think? You know what?
That looks like platelets.
What do you think?
I mean, maybe. What do you think, Asser?
Come on. Oh my goodness.
That's platelets?
Well, come on, just use your clinical judgment.
Platelets?
Yeah.
How did you even come up with that?
Okay, that's what it looks like to me.
Just do something.
Let's.
I mean,
Use your clinical judgment. Do you still
I
have
mean,
any of that?
my labs aren't really back yet.
You know what? Honestly, why don't we consider like something different? Why don't we consider like fibrinogen? Why don't we consider
Yeah,
something?
let me. Why
Just
don't we,
use your clinical
here, I
judgment.
know we can pull up the viscoelastic testing. It's running in real time, and we can kind of see if we can, gauge when our first actionable data shows up yet.
You know what?
It's aligned.
Huh.
No.
No. It's not just a line. I'm getting a champagne flute vibe going on right now.
I mean, I think it's maybe more of a brandy sniffer. What do you think?
Oh no. Oh, shit. Look,
Maybe just the.
I've had enough training in this. It's definitely a red wine glass kind
Are
of.
you sure about that?
I think so.
I don't know.
Guys, the patient's still oozing. How many blood products you've given already?
I mean, I've given like 3 red cells, 2 FFPs, 1 cryo. There's another cryo running. I don't really know what else to be giving here.
Well, can't you get something better?
You know what? I mean, how about some factor concentrate? How about some PCCs here?
Oh, no. I always get factor 7.
Yeah, we use factor 7 where I train too. That's a good idea. Let's try that.
I think PCCs may be helpful in this situation.
Okay, fine. I'll call up. I'll see pharmacy. Maybe pharmacy will approve it. It's very expensive. Hello. 1 hour later.
Oh, boy. I don't know. Is it getting any better in the field?
No.
Is it any less easy up there?
No. I ask you, let's just do something.
Look, I don't know what to do. I mean, maybe.
Spin the wheel.
Do you have any more
fibrinogen,
products?
Maybe.
I mean, come on.
Come on. I don't know. It's.
Here, get.
What am I gonna do? This is ridiculous. We'll give how about some cryo?
Hold on. No. Don't do that. Come on. Cryo's not gonna work. Let me give it a try. Come on, big money. I know we can do this. Come on. Oh yeah, DDAVP. That's
DDAVP it is. Don't you think that's
How did you come up with that?
I mean, we used some clinical judgment guessing.
Good clinical judgment.
I mean, honestly, just give everything.
That sounds good. Let's just give everything at this point.
I want to get out of here.
So, yeah,
Come on,
we're
guys.
never going to get home
Use
and
your
get this
clinical
chest
judgment.
closed. Based on what?
Yoy.
All right. So as we see, using the clinical judgment can be a little dicey. We really get into kind of a guessing game with what we're using. I need my clicker to forward along. So what are we going to do about this? So the problem is that clearly, unless you have some actual data to work on, this becomes kind of a guessing game. Yeah, your perfusion machine kind of tears up the platelets and maybe starts to activate some of the clotting factors, but who knows what to give at that point. So here's a real-time example of us getting results. You can see that for our, this is a TEG 5000 in our central lab. It took about 12 minutes to get it actually collected and sent off to the lab. And then it takes another, total time of 1 hour and 18 minutes just to get the result back. We sent off some fibrinogens in the case 52 minutes before it finally shows up. CBC to get a platelet count, 1 hour, 25 minutes. I mean, in that time, I've given all sorts of blood products. The coagulopathy is ongoing. And my surgeon sure as heck don't sit around waiting for me for an hour plus to get some data to go off of. So enter the Quantra. So this is a real-time viscoelastic testing device. It's a little box. It's about this high. And it sits in the operating room, a very small footprint. And it has little cartridges that you are able to basically take the blood, put it in a little tube, stick the cartridge into the machine, and within about 12 minutes on average, you will have results back. So this thing uses sonic estimation of elasticity and resonance, sonoriometry, which basically is ultrasound. little ultrasound pulses are sent into the blood sample as it's sitting in the cartridge, and the ultrasound bounces back, and as the blood coagulates over time, the stiffness of that blood changes, and the ultrasound waves coming back at you change, and it's measuring the development of that clot, similar to what goes on in more traditional viscoelastic testing. The clot times and clot stiffness values are measured from the evolving shear modulus. And so you end up with a screen like this. If you like the curves and you like sitting there looking at wine glasses and trying to figure out that type of thing, you do have that available if you want to see the curves on the Quantra device. However, they come with a very user-friendly interface that even my little residents and interns in the OR with me are able to interpret, that have these parameters listed on them, because it's hard to remember all of the wine glass shapes. And if you're a resident trying to do ROTIM and can't remember if the FIB-TIM or the X-TIM and what your X-TIM told you and FIB to you about last time, you might just want to go with the nice little user-friendly interface. So here we have the clot time is our first parameter on here. This is like your ACT. It's how many seconds does it take to get the blood to coagulate. The clot time with heparinase is on here. So the heparinase enzyme removes the effect of heparin. So you can see the underlying coagulopathy that's going on underneath. And that'll be able to tell you if you have underlying platelet deficiency, clotting factor deficiency, et cetera. This clotting time ratio is a ratio of the clotting time over the clotting time with heparinase. Or sorry, yeah, that's the right way. Clotting time with the clotting time with heparinase. And so if that clotting time is higher, and the heparinase is normal, as that clotting time ratio goes up, that tells you still have heparin effect if it's over 1.4. And that would tell me I need to give more protamine to correct whatever oozing is going on up here in the field. Down here we have clot strength. So if you've seen the surgeons pull out those real, new goopy clots that just kind of dissolve between your fingers, those are very fresh clots that haven't developed fully yet. And what we need is a strong, stiff clot that's actually going to hold and not have the patient keep oozing. The problem with viscoelastic testing is when you start looking at the alpha angles and the mean amplitude, you really can't tell the difference of what contribution the platelets and fibrinogen are to that. It's all kind of one thing. It was traditionally taught the alpha angle is a little bit more specific for the fibrinogen polymerizing in there, and then the mean amplitude is as the platelets are coming in and plugging the holes in that fibrin mesh network. But it's really hard to tell what contribution you need and if you should be giving platelets or fibrinogen based on that. So here we have a PCS, which is a platelet contribution to clot strength. If you're in the green, you're good. If it's lower than that, you might want to consider giving some platelets. And similarly, we have a fibrinogen contribution to clot strength. Again, very user-friendly. If you're in the green, you're good. Lower than that, you might want to consider giving some cryoprecipitate or even fibrinogen concentrate if you have that available to you. So this is our experience at University of Florida. I'm a cardiac anesthesiologist there, as well as in critical care medicine, where we instituted these things in our operating rooms, and it made a very big difference. So at our place, these prolonged central laboratory processing times well over an hour was resulting in us basically just ordering a bunch of blood products like we're making fun of up here. We get all the blood products in the room. We try to gauge when we'd send off our viscoelastic testing and our CBC and fibrinogen still on bypass. And then when stuff comes back an hour later, I would go and select the blood product I thought needed to be given based on the viscoelastic testing. And that was resulting in a lot of waste. We're ordering a lot of wasteful blood, a lot of blood products that end up getting sent back to the lab. Red cells can probably go back and sit and be given to the trauma patients when they come in. But stuff like platelets and cryo, if this stuff stays out for more than 4 hours from the lab, you have to send it back, and it probably is going to get thrown in the trash after 4 hours. The cryo at our place gets quarantined. If it's more than 4 hours out, they have to retest it, and then they can maybe repackage it and send it to another patient that might use it. So some nice person that came in and very kindly donated their blood is getting it thrown in the trash because of our wastefulness. So here we initially got them in with a little 6-week trial. We put them up against the competitor, which was the TEG 6S. And we looked at what happened in the 6 weeks time that we put them in there. We had everyone trained by reps from both the TEG 6S company as well as the Hemosonics Quantra company to how to do them. And then as control, I looked back at 596 patients from back in 2019. And I chose that year because that was before COVID happened. And with COVID, we had a lot of interruptions and elective surgeries where we just weren't doing them. I didn't want to skew the data toward a bunch of more just only urgent surgeries and low numbers. So that's why we used that. We came up with algorithms for transfusing. And then our project design, we had our statistician run all the numbers to make sure everything was kosher, to make sure the groups were equal. Our primary outcomes was to look at the number of blood units ordered and wasted, and then to compare the number of units that were actually transfused to the patients. So here's initially, we had 72 patients that we looked at, and we had 30 something in one group, 30 something in the other group. I'm going to whip through all this boring data fairly quickly, but there's no real difference in our patient characteristics, no real difference in the baseline lab values and baseline hematocrit and stuff of people coming in, no real difference in their pre-op anticoagulation use. No differences in the type of surgery. We do a very wide variety of surgeries there, a lot of major aortic cases. No difference in the cell saver use. There are no differences in the PCC, factor 7, fibrinogen concentrate, DGAVP, vitamin K administration between the two groups. And so here's our results. So here's just comparing the times of the two devices. So the Quantra Qplus in our hands was 12.9 minutes versus the TEG 6S was 24 minutes. So that right there is a win, because in the time it takes me to get my stuff sent from the OR off to the lab, I've actually got a result already that I can work off of. Just to compare, this was the data from this particular study. All of the control patients getting a TEG with heparinase took 83 minutes, took 9 minutes to get it collected and arrive in the lab, and then to actually run it and get a result, 74 minutes for a total of 83 minutes. For the TEGs, 81 minutes, 11 minutes to get it collected from the OR, hauled off to the lab, and then 70 minutes to get it a result. So here's our results. So if you're looking at the blue is the control, the orange is patients getting a point of care device. And this was a mix of the two devices for this one. We'll get to just using purely the Quantra Qplus next. And then we're looking at the very far side here is red blood cells transfused. And you can see a drop in the transfusion. And then this is the waste of red blood cells. So a massive decrease in the amount of waste, because we're just not ordering all this crap and giving it back to the lab. Similarly for the FFP, transfused and wasted. So the transfused is more toward your left on the screen. And then the waste, huge decrease in the amount of waste there. Similarly, we have our platelets here on the left. The control is in blue, orange. We actually gave a little more platelets based on the results from these point of care devices. Big decrease in the waste of the platelets. And for the cryoprecipitate, maybe a tiny bit less, and then a decrease in the waste of the cryo. So this was our reduction, 86% reduction in waste of platelets, 95% in waste of FFP, 76% in red cells, 42% in cryo. So our lab medicine guys loved us because we weren't ordering all this stuff and wasting it. There was a trend toward reduction in transfusion. Didn't reach significance though. And I said, well, maybe it's due to the small sample size. I mean, there's only 70 people. So the data says we need some more data. So we said, let's do this bigger and better. So we got our Quantra Qplus devices. Everyone was able to vote on what device they wanted. Because this one was the fastest and also allowed us to differentiate between platelets and fibrinogen contribution to clot strength, that's why we decided to go with it. We looked at 253 patients in over a 6-month period, and again, compared them to my control of 500 something patients. Again, primary outcome was how much blood are we ordering and then wasting, and then how much blood units are actually being transfused. Same thing, we had our statistician run all the fancy data, kind of similar results as far as our patient characteristics, same characteristics there, same baseline lab values. I put if there's any slight difference, I put it in yellow there. Differences in preoperative anticoagulant use, not a lot of difference between the groups, no real differences in the type of surgery. And here is more the meat of what we were trying to achieve with this. So this graph is showing the reduction in transfusion that was achieved by implementing a real-time point-of-care device that gives you rapid, actionable data that you can quickly make a decision off of. So to the very far left of your screen, you see red blood cells Where it says pre-point of care, this is the amount of blood transfusion of red blood cells. Each one of these lines is a single case and the number of units given in that case. And then post-POC is post-point of care. So you can see the reduction in transfusion of red cells. Because we were able to more quickly correct the coagulopathy, we're not having to make up for it by giving red cells until we actually get all the oozing stopped. Similarly, we're going to look at the units of platelets. So in the second from the left over there, you see platelets. Pre-POC is before point of care, before Quantra, and you see the decrease after point of care. Next up, we have FFP. We had a huge drop in the amount of FFP given. We were apparently giving quite a lot of FFP, and I think some people probably just start giving red cells with FFP to kind of run sort of like a mass transfusion protocol to balance everything out until they can actually get the coagulopathy under control. Similarly, we have our cryo is on the far to your right of the screen there. And again, big decrease in the amount of transfusion of cryo. Interestingly, so we looked at the percent of patients who got a transfusion of any kind. In the orange toward me, you'll see the before we instituted the Quantra, 63.8% of our patients were getting a transfusion of any kind, and we dropped that down to 54.9% after instituting the point of care devices. And then if you look at the mortality, so we have discharge mortality if you made it out of the hospital, and then 30-day mortality. Anytime you give a unit of blood, that is a known independent risk factor that increases mortality. It increases all sorts of negative side effects as far as immune suppression, wound infections, deep sternal infections, prolonged time to extubation, atrial fibrillation. I could go on and on with all the bad effects one little unit of FFP or platelets or cryo can give. And so we were able to show a big decrease in not only our discharge mortality, but also our 30-day mortality by reducing the amount of blood products that we are using. This is the reduction in blood waste, similar to that first slide you saw. So we have red cells, platelets, FFP, and cryo going across. The bar to your left is before we put in the Quantras. The bar to the right is after we put in the Quantras, and you can see the decrease in waste that we achieved. If you actually look at the numbers of how much waste, 76% reduction in platelets, 97% reduction in FFP, 77% reduction in red cells, 90% reduction in waste of cryo. Y'all, this is in 4 cardiac operating rooms. We have, I don't know how many, probably 60 to 80 within our whole hospital. So this is the effect that just, a couple of operating rooms can have. Imagine if we put these in other operating rooms like our trauma, our liver, other areas, which we are actually now trying to get them into. Here's the number of blood components that we used within the year of 2019. This is just in the cardiac operating rooms. We used all these units for a total of 2,348 units. If you were to reduce those units by the amount of waste, so here first, here we have our average indirect cost of 1 unit of blood is about $1,200. That's an old figure, probably with inflation, that's probably up around $2,000. But just since that's the published figure, that's what I went with for kind of a really cursory cost analysis on this. If you multiply that by the 2,000 something odd units that we wasted, you end up with $2.8 million we just blew through. I don't know about y'all, but I could use a salary bonus if I start saving some of this money. So wasted blood products. And then up here, if you were to reduce the amount of waste by the percents that I showed during that 6-month period in 1 year, there's an estimated cost savings of $2.3 million. And so you can make it rain with that. That is really quite an impressive cost savings. And when this is how you have to talk to your lab medicine people, because for some reason the impact on your patient's mortality, ICU length of stay, outcomes, somehow that doesn't quite get into their head. When you start talking some dollar bills, now they pay attention to me and they are very happy to start putting them in other operating rooms. So some of the future directions we want to go with this is actually to get them into our cardiac surgery ICU. I work up there also. And we want to start using them on our ECMO patients because as y'all know, especially with COVID, ECMO was originally designed to be like a 1-week deal while someone got better. And I'm sure y'all have had patients that are just sitting around on ECMO for weeks and months at a time now, awaiting lung transplants. And during that time, they develop a lot of coagulopathy issues. You've got oozing out the cannulas, and it's very difficult to manage. And so we're going to start trying to use them in our ECMO patients as well and get some data for that, which I think is very exciting. So conclusion, implementation of the Quantra Qplus devices in the operating rooms can reduce the clinical guessing, clinical wheel spinning, and provide reduction of waste because it provides the actionable, timely data. If you put the Quantra Qpluses in there, you're going to probably reduce your blood transfusion as well, which has a lot of implication on patient outcomes. And it can provide cost savings, which again is important in this day and age. We can't blow money. We've got to be conscious of what we're doing, and blood is really a precious resource that we don't want to waste. So that concludes my talk. We're going to come back to the operating room just for 1 second here. Oh man, I thought y'all would never get that oozing to stop, guys. Goodness. Yeah, I mean, it was a rough case. Yeah, it's been a long one. It's been real. But listen, thank you, sir. Appreciate you. Glad we got the chest closed. It's yeah. It's all right. So, long case, man. I don't know. There's got to be a better way. What is that? Hello? Yes? I have your results for your Viscoelastic testing. Now they're ready? Honey, you need to get you a Quantra.
Awesome. Thank you.
Thank you. I'd like to thank my colleagues from Hemosonics, Asser Jurgis and Mike Skinner, for humoring me by portraying our perfusionist. Asser actually was a perfusionist before he joined Hemosonics. And Mike, thank you for playing our surgeon. No problem. And I will be happy to take questions from you guys if you have any on how we implemented these. Also, come visit us. We'll all be around booth 7 in the vendor area. You can actually see the little devices and see the cartridges and see if you think it's something that might help y'all in your institution.
Thank you. I think all of us here can relate to this scenario. We've lived it many, many times in the operating room. So that was an excellent presentation. Thank you.
Thank you.